Tubal ectopic pregnancy is the most common form of ectopic pregnancy. The key things to understand are that you see an adnexal mass which is separate from the uterus and separate from the ovary. That is likely then to be an ectopic pregnancy. In that group of adnexal masses, there are 4 types of images that you can see. The most common is the blob, which is just something that is somewhat amorphous. It doesn't look like ovarian tissue, it doesn't look like an ovarian cyst, and it's just sitting there. The second most common is the bagel sign, or the donut. And that's when you see an echogenic, a bright, thick ring with a small cystic center. And what you're looking at is the gestational sac outside the uterus. It may be surrounded by a bit of a blob, and the blob is actually the hematoma, the hematosalpinx, the blood that's in the fallopian tube. That's the blob. So you might have a bagel with a little bit of a blob. Those 2 forms of ectopic pregnancy account for at least 2/3 of the appearance of the tubal ectopics. The least common but most definitive appearances of tubal ectopics are when you have a yolk sac inside of the donut, or if you have an embryo. And if you have an embryo, it might or might not have cardiac activity. Those are actually the least common, but clearly are definitive for an ectopic pregnancy in the tube. After the common tubal ectopic pregnancy in the tube outside of the uterus, the next most common ectopic pregnancy is when it is in the tube, in the portion we call the interstitial tube. That is the small portion of the tube within the myometrium of the uterus, connecting the endometrium to the extrauterine portion of the fallopian tube. If a pregnancy develops there, it can give you a lot of difficulty figuring out exactly where it is, and it depends on how early it is. If the pregnancy is early and you have a 5-week sac, it may be completely surrounded by the myometrium, but it is not in the endometrium. To figure this out, you need to see where the endometrium is and where the myometrium ends. We have found that 2D and 3D coronal reformats of the endometrium are very helpful. As the interstitial pregnancy grows, and it often does get fairly far along because they tend to be highly vascular, it starts to bulge out of the uterus into the tube. And the bigger it gets, the more it looks more outside the uterus, and you may think it's a tubal ectopic. To figure out if it's actually interstitial, you can follow the endometrium into the interstitial portion of the tube to that interstitial ectopic. You can look for the claw sign, which means that there is a rim of myometrium partially surrounding that gestational sac. Another thing you can do is push gently at the uterus with the probe and watch what happens. If that pregnancy is partially still in the uterus, in the interstitial tube, it will move with the uterus and not separately from it. In addition, the interstitial ectopics are usually quite vascular. They derive a lot of blood supply from the uterus, which is highly vascular, so turning on the color may help as well. We have found that when the pregnancies are very early in the interstitial portion of the tube, you sometimes have to watch it and not immediately act upon it. As it bulges out more, you can be more confident with your diagnosis. Why does it even matter to make that distinction? It is important for the clinicians. Treating an interstitial ectopic pregnancy can be much more difficult than treating a classic small tubal ectopic, which may respond very well to medical therapy. There are 2 other types of ectopic pregnancies that actually occur in the uterus, but not in the endometrium. Those are the cervical ectopic and the cesarean scar ectopic. The latter of those, the C-section scar ectopic, is becoming more and more common in the day and age of many cesarean sections. Cervical ectopic pregnancies are quite rare. Most of the time, if you see a gestational sac somewhere in the very lower aspect of the uterus or in the cervix, it's usually on its way out. That is clearly the most common thing to happen, is spontaneous abortion. Those pregnancies often have a very flattened, distorted gestational sac. rarely will see an embryo with cardiac activity. That sac may actually slosh back and forth and move all by itself without anybody pushing at it. And if you put color Doppler on it, which you can because it's in an abnormal location, you will not see trophoblastic flow around it. Trophoblastic flow is the kind of flow that you see as the placenta develops. C-section scar ectopics and cervical ectopics are implanting low or in the cervix, and they won't move around. They often have an embryo with a heartbeat, and if you put the color Doppler on, the placenta is actually growing in those locations, and you'll be able to find that flow in that location.